urticaria. And typically urticaria occurs with angioedema, so it's really difficult to discuss one without the other. Majority of the cases are they usually coexist, so I couldn't just discuss urticaria without mentioning the pathophysiology and management of angioedema. Although we will not be discussing hereditary angioedema, which is a much rarer condition. I will also discuss the different types of physical urticarias and try to present each with a specific case presentation to kind of magnify the diagnosis. I will briefly present the differential diagnosis for chronic spontaneous urticaria, which is the new nomenclature from chronic idiopathic urticaria. And lastly, we will review the treatment guidelines published by the Joint Task Force for Practice Parameters. And I will contrast that with the recommendations by the European Allergy Council and the WAO, or the World Allergy Organization, because there are some differences. First, we'll discuss a review or go over the diagnosis of acute and chronic urticaria. I'm sure all of us have encountered urticaria in our practices. As a pediatrician and as an allergist, this is actually the bane of my existence, because it's a very difficult condition to treat, and I don't know if Dr. Genuino will agree with me in saying that it's, you know, there's a lot of patients with significant morbidities, a lot of side effects of medications. Some of them come in after having been on steroids for a long time, and I will comment on those treatment later on in the talk. So typically, the term acute is a very specific way to classify urticaria. The duration has to be less than 6 weeks, and by history, these lesions are fleeting, evanescent. Patients complain that their lesions are highly pruritic. They can erupt in any part of the body, and usually the wheals last less than 24 hours and can re-erupt in different sites. On examination, patients come in with actually different colors depending on their skin pigmentation. They could be raised or indurated, salmon pink, or erythematous lesions with raised borders and central pallor. The borders are usually well demarcated. Sometimes these lesions can be confluent, and typically you elicit this history that they blanch, these lesions blanch with pressure. Very importantly, acute urticaria or just run-of-the-mill urticaria do not leave any residual bruising, because if they do, if there's any staining of the skin, bruising of the skin, it would be important to send these patients for further evaluation to rule out urticarial vasculitis. I reproduced all my pictures with permission. And so this is a baby came in with post-viral infection. And these are typical urticaria lesions for infants and children. They usually come in with target lesions all over the body, face, neck, and even areas with hair or glabrous skin. Most often, the pathophysiology of acute urticaria and angioedema is driven by IgE and the activation of basophil mast cells. So IgE presenting with an allergen causes basophil mast cell degranulation. So in essence, histamine and vasoactive peptides like leukotriene, LT4, and prostaglandin, specifically PGD2, are released, and these are very potent vasodilators. So after vasodilation results, there's a significant release of plasma, and depending on the level of the skin, it shows up as urticaria if it's in the mid to upper dermis, and if it occurs in the lower dermis and subcutaneous tissue, it manifests as angioedema. Usually this process occurs immediately, and after 48 hours, there is resulting perivascular non-necrotizing infiltrates with very few cells that are visible in biopsy. So usually this is a characteristic of the acute lesions. Sometimes, and more rarely, acute urticaria is caused by a direct response to proteases that are released or contained in food, inhalant allergens, and infections by direct activation of the complement cascade. So it can bypass mast cell and basophil activation and does not necessarily require IgE. So WAO reports a significant burden of disease, and there could be a lifetime prevalence of 20%. And this is very similar to the data that's reported in terms of prevalence by the Joint Task Force for Practice Parameters. So this stands for Joint Task Force, and it's a commission that has is representative of the two allergy societies in the US, and they report a lifetime prevalence of 15%. The reason I mentioned earlier that it's important to discuss urticaria and angioedema together is because majority of the time these processes coexist. 40% of the patients present with just urticaria and 10% present with just angioedema. If angioedema occurs without urticaria, this gives us a clue that it could be bradykinin-mediated, either as a side effect of drugs or ACE inhibitors, or C1 esterase deficiency, which is very rare. I just wanted to show more pictures of urticaria just to show that it can present as different sizes of lesions and different colors and different distribution. Meanwhile, acute angioedema, by history, they're non-pruritic. Sometimes these patients complain that the lesions are painful and the swelling occurs deep in the dermis and the subcutaneous tissue. And usually it affects the peripheral tissues such as the hands and feet, but in some cases it could also affect the face, lips, and eyelids. In rare cases, and it could be more life-threatening, angioedema could occur in the gastrointestinal tract and cause unexplained abdominal pain. So a lot of these patients, since the swelling is not visible, they may have had a history of unnecessary appendectomy or exploratory laparotomy. On examination, the angioedema lesions are usually present with ill-defined borders. The angioedema is non-pitting, and they may or may not have urticarial or erythematous lesions. As mentioned, the more serious involvement would include the gastrointestinal tract, the larynx, and genitalia. So this is just a picture depicting a typical lip angioedema. It extends to the beyond the vermilion border, so that's why the borders are ill-defined. And you can see the face of this patient. It's almost shiny from the extent of the swelling. This is angioedema of the hands and fingers. It shows that it can obscure or spread and obscure the bony borders or the bony landmarks. This is an example of a patient with eyelid angioedema. The important caveat when discussing acute episodes of urticaria and angioedema is the history. If there is multi-organ involvement, such as hoarseness, which can indicate laryngeal edema, wheezing, which can indicate involvement of the lungs, vomiting and diarrhea, which can indicate GI involvement, hypotension, which can indicate cardiovascular involvement, or neurologic involvement in manifesting as change in mental status, it's important to make sure that the patient is not anaphylactic. And this should be high in a differential diagnosis for all patients who come in with that history. And in the interest of time, I will not be discussing anaphylaxis, but there is a current and revised practice parameters published in the Annals of Allergy, Asthma, and Immunology in the November issue. And I've included that here for your reference and further review and study. So this is just a summary, acute versus chronic. The duration is key. Lesions that last for longer than 6 weeks come under a different category and may require a different set of laboratory testing. Usually acute lesions last for less than 24 hours but may recur. In majority of cases, acute cases have an underlying reason that you could identify, you could test in the lab, and usually help the patient clarify the reason. But the vast majority of cases of chronic urticaria are idiopathic, and that's why I like to emphasize this in this part of the talk. History is crucial in helping our patients and also teasing out what laboratory procedures to order, what laboratory tests to order. So in the history, I usually ask when did the lesions start, what were the triggers surrounding the onset of the lesions, the timing of the onset of the symptoms, is it temporally related to weather change, pressure, food, temperature, sweating, inhaling air allergens, going to visit a family with a dog. So these are important clues in the history that will help us focus on the management. And also an important component of the history would be response to treatment. Another historical piece that I think is important is if there are any medications. So oral contraceptive pills are notorious for causing urticaria, and sometimes the patients don't think that that's a medication and they would not include it in their history, but it's a very common cause of acute urticaria. Any past medical history, such as history of thyroid disease, history of travel, history of atopy, history of allergies is also an important piece of our history taking, because again, it'll clue us in on possible causes of the urticarial lesions. This is just a list of the common causes of acute urticaria and angioedema that are IgE mediated, and these come under the purview of allergy and immunology. That's why it is interesting to me. So air allergens, food, drugs, specifically antibiotics and non-steroidal anti-inflammatory drugs are common culprits. Stinging insects causing venom hypersensitivity is another common cause. Parasites as another established cause for acute urticaria, and post-viral infections, and rarely Helicobacter pylori can also cause acute urticaria. So the workup for these patients, especially if we've established that it's IgE mediated, would be epicutaneous skin testing. The recommended or the preferred method would be prick, but there are still other allergists who use scratch testing for food and inhalant allergens. There are specific techniques for doing drug allergy testing, and this could include intradermal skin testing as well. The only validated way to measure specific IgE would be immunocapras. This is a kit that was developed in Sweden, and only 8 foods have had published positive predictive values that have been validated by double-blind placebo-controlled food challenges. So the reason I put this in this slide is because we see a lot of patients who undergo an extensive battery of food allergy skin tests or IgE testing for food or IgG testing for food, which are unnecessary and are not helpful for these patients, because these results are usually not validated by published studies. In some cases, stool for ova and parasites, if the patient comes in with a history of travel, to clarify whether the urticaria is caused by parasites, and again, serology for H. pylori or other viral infections if the history is suggestive. Majority of cases, if you divide up the prevalence of acute versus chronic urticaria, 70% of our cases would be coming under the acute case. And this is more common in children and more common in patients with history of allergies or atopy. Of the cases presenting with chronic urticaria, the vast majority are chronic, spontaneous, or idiopathic. And only 20% have an underlying cause triggered by physical urticaria. So usually chronic urticaria is described as continuous or intermittent lesions. Typically they occur daily for longer than 6 weeks. And this is a condition that's more common in adults, and there's a female preponderance, almost 2 to 3 to 1. So it's more commonly seen in women. And there's usually no history of allergies in these patients who present with chronic urticaria. So let's shift gears, and I go back to my learning objectives just to help us or guide me in terms of an outline for the talk. I'm presenting physical urticarias with case presentations. So I have a 32-year-old Asian female who has had a history of extreme generalized pruritus and hives that erupt on her neck and chest before public speaking. This causes a lot of anxiety. She reports that these lesions are papular, sometimes linear, or sometimes welt-like rashes on her legs when she jogs or runs outdoors. Usually these rashes resolve when the activities are over and do not recall unless they have triggers. So what would be a differential diagnosis for our patient? Correct. Correct, Dr. Santiago. So I have listed the different types of physical urticarias that fall under chronic urticaria, and I will present some cases to show examples of each of them. But this patient that we just saw or discussed has cholinergic urticaria, and it's usually triggered by sweat, stress, anxiety, and I put here exercise, but there's an emerging set of exercise-induced urticaria that may require exercise to be a separate type of physical urticaria on its own. Eating spicy food or taking hot showers would be another important trigger for cholinergic urticaria. All right, so Mary Casal, a big group of dermatologists, published this breakdown in terms of the prevalence of the different physical urticarias, and by far the most common cause of physical urticarias would be dermatographism. 52% of all cases of physical urticaria falls under dermatographism, and with the other 4 distributed in smaller percentages. So cold-induced urticaria is 15%, pressure-induced urticaria would be 10%, and cholinergic urticaria would be 3%. Solar and exercise-induced have 1% each. So just a small blurb on cholinergic urticaria. It occurs between the 2nd and 3rd decade of life. It's usually a benign process, or it's not associated with any anaphylaxis. It's caused by histamine release from direct stimulation of the mast cells on the skin. So again, the treatment would be prevention. So avoid the triggers, avoid stress, avoid nonsteroidal anti-inflammatory drugs, take lukewarm or cool showers. And if it becomes debilitating, I usually put my patients on antihistamines before a stressful situation. Okay, this next case is FM. It's a 21-year-old Asian male, actually a Filipino male, with a history of eczema during infancy, who came in with a history of acute recurrent linear hives when he scratches his legs, chest, and abdomen. He lives in the dorm. He left home to be in college a few hours from home, and usually this is triggered by him moving away from the home. His rashes and itching last for a few hours and then resolve. He describes his lesions as, quote unquote, "I can write on my skin by scratching." So what do you think does our patient have? So the next classification of physical urticaria would be dermatographism. So this is in our graph, is majority of cases with a physical urticaria manifest as dermatographism. So these patients come in with dramatic lesions on their skin, especially on areas that they scratch or touch or irritate. It affects 2 to 5% of the general population, and it results from direct mast cell degranulation, usually from scratching. So the initial lesion is a white lesion caused by vasoconstriction, and then subsequent pruritus and erythema results with the linear urticarial lesions. It resolves within minutes, so sometimes you could actually have the patient demonstrate it to you during the clinic visit, and by the time that your clinic visit is over, the lesions have disappeared. Again, if it's a debilitating condition or concern, I put FM on antihistamine at bedtime and to see if this will calm this process. It could be concurrent or be a comorbidity with other inducible urticarias, and it's the most common form of physical urticaria. It peaks during early adulthood. Oh, I just put this back so we could see the distribution that we discussed earlier. Now, there's another patient, and this is going to lead us to another diagnosis. This is a 48-year-old female who presents to clinic with new symptoms. She suffers from large, palm-sized, extremely pruritic welts on both buttocks after sitting on the airplane or car for prolonged periods of time. These lesions erupt after a few hours of arriving at the destination and last for days. And by recall, this patient states that there's a history of welts on her shoulders when she's carrying heavy shoulder bags. What is your diagnosis? What do you think this patient has? Yearbook-induced pressure urticaria. So GT has a type of physical urticaria caused by pressure. So pressure urticaria is caused by prolonged sitting, laying down, or tight clothing. There is actually a method for diagnosing or proving that that's what your patient has. And this was published in 2004 by Lawler and Black. So you put a 15-pound weight that you could suspend by arm straps over the shoulder, and you have the patient walk around for 15 minutes. And then when you remove the weights or the straps, you can actually document the induration and the tenderness caused by the pressure at least 2 hours after the testing. Okay, this is SN. He's a 7-year-old Caucasian male who presents with a 1-year history of having developed diffuse urticarial lesions, dizziness, fainting a few minutes after he went swimming in a cold lake during their summer vacation. He subsequently developed wheals. When he came out of the pool, or was brought out of the lake, sorry, he broke out in wheals on the exposed skin. Subsequently, the mom reports that when he's waiting for the school bus during the winter months, his exposed skin on the face and on the ears would break out in rashes. What do you think our patient has? So SN has acquired cold-induced urticaria. So this is typically caused by rapid changes in skin temperature by immersing the body in cold water or exposure to cold wind. So that's why SN develops facial wheals and urticaria when during the winter months. So this is just an example of cold-induced urticaria. The way we, again, this is reproduced from DermNet. The way we can diagnose this is by using the ice cube test, or you could put ice on a small glass and put it on the skin. So you could leave this on the skin and for 15 minutes, and when you remove the ice cube during the rewarming phase, you could elicit the urticarial lesion. This is called the ice cube test. So the pathophysiology would be wheals and erythema and pruritus developing within minutes to 48 hours of exposure. Occasionally, this can be more severe. It can cause fever, headaches, dizziness, loss of consciousness, and hypotension. So these patients are at risk for drowning and suffering from an anaphylaxis type episode. So I usually send these patients home with an EpiPen autoinjector or a pre-filled epinephrine syringe. The caveat here is the negative ice cube test does not rule out all types of cold-induced urticaria. In rarer cases, there are familial Muckle-Wells, familial cold autoinflammatory urticarial syndromes falling under the cryopyrin-associated periodic syndrome, familial cold, autoinflammatory urticaria, or Muckle-Wells. So these are just rare conditions caused by mutations of the NLRP3 gene. So usually these patients also had sensory neural hearing loss, amyloidosis, and cutaneous lesions. It's probably, it's one of the rare conditions, but there's actually research on it in its management, medical management. Differential diagnosis of chronic spontaneous urticaria. Again, majority of these cases are idiopathic or no identifiable cause. The prevalence is about 0.5 to 5% depending upon your reference source. It has a 1.4 per year incidence. It's very difficult to differentiate chronic spontaneous urticaria from chronic urticaria vasculitis. So usually this subtype of vasculitis is associated with autoimmunity and hypocomplementemic disorders. Some classical historical features to differentiate CSU with urticarial vasculitis would be the presence of pain. So usually the urticarial lesions for vasculitis are painful, sometimes even presenting with a burning sensation. They usually last for more than 24 hours, and these lesions are palpable and non-blanching. There is residual bruising and staining of the skin. Okay, so I've listed here the differential diagnosis for chronic spontaneous urticaria. Rarely is food, inhaled allergens, and drugs involved in the underlying pathophysiology. So aside from idiopathic or unknown causes, chronic infections such as hepatitis B, C, herpes simplex, Epstein-Barr virus, and Helicobacter pylori are listed under possible causes of chronic spontaneous urticaria. Other systemic conditions involving low complement levels or immune-mediated conditions such as JRA, SLE, Sjogren's, cryoglobulinemia, hypo and hyperthyroidism is also listed as possible causes. But again, these are all rare. And even rarer would be neoplasms. It's been reported in ovarian tumors and other lymphoproliferative malignancies. So chronic spontaneous urticaria is actually the the orphan condition in allergy, because it's the pathophysiology is very poorly understood. 40% of these cases have a positive autologous serum skin test. So you extract the patient's blood, centrifuge the blood, and separate out the serum and re-inject that serum as part of the skin test, intradermal skin test. So these patients are, this suggests autoimmunity in these patients. 30 to 50% of them have IgG antibodies to the high affinity IgE receptor, specifically the Fc epsilon R1 alpha. And a smaller percentage, 10%, have direct antibodies to IgE, not just the IgE receptor. 25% have anti-thyroid antibodies. This percentage clues us in to a lot of these patients getting thyroid function testing as routine parts of their evaluation. The biopsies for these chronic lesions show mixed cellular infiltrates, which include polymorphonuclear cells, eosinophils, neutrophils, basophils, and different subtypes of T lymphocytes, namely the CD4 and CD8 population. And again, the differentiating key finding in chronic spontaneous urticaria is the absence of perivascular necrosis. Whereas in urticarial vasculitis, there is a perivascular necrosis that's seen on biopsy. All the recommended guidelines, all the data recommends limited work, if at all. So these patients usually undergo a battery of tests which do not yield any clue as to the underlying cause of their disease. So limited workup is the way to go. Usually I limit my evaluation to very few tests that include a CBC, urinalysis, C-reactive protein and ESR, liver function tests to look for elevated liver enzymes, thyroid function testing, and antibodies. And very rarely have I sent patients for a skin biopsy. In a couple of dermatology publications, they've shown that laboratory testing, blood testing, all of these that we've mentioned have very limited utility and have identified less than 5% of the underlying etiology of CSU, or chronic spontaneous urticaria. So sometimes we do this just to be able to reassure the patient that there is no serious underlying pathology. So it's recommended that testing be focused based on the history and physical exam. And the current commercially available assays for surface markers, such as anti-CD203C and basophil histamine release, so this is a marker for mast cell activation, have very limited clinical application. And I think autologous serum skin testing is, although I've done this in fellowship, is usually reserved for research purposes. Lastly, so this will be the summary of the current treatment guidelines that were published by the Joint Council, the Joint Task Force. First, we start by identifying the triggers. That's why we talked about this in the previous slides, that the history is key in a lot of these patients because it will help guide and focus our management. And once you've identified these triggers, avoidance and educating the families on how to avoid these triggers or remove them from the diet are important. And then the stepwise approach I will be discussing in more detail. You can start off the patient in different steps depending upon the severity and the history of response to previous medications. So step one, which is the most well-studied recommendation is monotherapy with a non-sedating antihistamine. Usually non-sedating antihistamines would mean the second generation and third generation antihistamines or H1 blocker. At follow-up, if there's no response in 2 weeks, you are, you're able or recommended to go to step 2. So I wanted to just do a quick blurb on histamine. Antihistamines are usually inverse agonists for the type 1 histamine receptor. First generation antihistamines are sedating because they cross the blood-brain barrier. And I put here examples of first generation antihistamines with designation of their safety in pregnancy and breastfeeding. So diphenhydramine, chlorpheniramine, cyproheptadine, hydroxyzine, and doxepin are important examples of first generation antihistamines. Hydroxyzine and doxepin are category C for safety in pregnancy and breastfeeding. Types of second generation antihistamines include loratadine, cetirizine, and terfenadine. Terfenadine was taken out of the market, I think a decade ago, due to cardiac side effects. Now, the third generation antihistamines are technically second generation modified molecules of second generation, so antihistamine. So levocetirizine would be an enantiomer of cetirizine, and desloratadine is the active metabolite of loratadine. Fexofenadine would be Allegra, and the only medication, third generation antihistamine that's safe for pregnant women is levocetirizine. Now, step 2 for treatment, if the patient when the patient returns and the lesions have not improved, we are able to increase the dose of non-sedating antihistamines up to 4 times the recommended dose. So some of my patients have gone up to 40 milligrams of Zyrtec or Claritin. Or you could add another non-sedating antihistamine or add a leukotriene receptor antagonist or an H2 blocker, such as cimetidine or ranitidine. Or the other option would be to add dating first generation antihistamine at bedtime. The 2 examples of leukotriene receptor antagonists would be montelukast or zafirlukast. These are potent inhibitors of leukotriene, especially leukotriene D4, which is a lot more potent than histamine in causing a wheel and flare response. So that's why it's been recommended for use in urticarial management. If the patient still doesn't improve, step 3 recommended would be start potent antihistamines such as hydroxyzine or doxepin. The note on doxepin is that it's a tricyclic antidepressant, but it was found to have H1 and H2 receptor antagonist function. So the recommended dose would be 50 to 150 milligrams at bedtime. Doxepin and hydroxyzine are very sedating, so you would really want to give it at bedtime and caution the patient about operating machinery or driving. The difference between the US guidelines and the European Asthma, Allergy, and Clinical Immunology and the British Society of Allergy and Clinical Immunology guidelines is that the Europeans are a bit more liberal with using oral corticosteroids. The recommendation to start oral steroids is not in the US guidelines. So this was something that was just approved. This was a very recent addition to the treatment guidelines. Step 4 for refractory urticaria lesions, the FDA approved using OMALIZUMAB, which is an anti-IgE, a monoclonal anti-IgE that is given once a month. Again, step-down therapy for these medications can occur every 2 to 6 weeks, and these patients require very close follow-up. Just a note on omalizumab, it's a humanized monoclonal IgG antibody that it selectively binds free IgE, so therefore it inhibits binding and activation of the mast cells and basophils. So it binds on the high affinity IgE receptor. And this is well studied in asthma, and it's actually part of the step 6 management of asthma. But then the FDA also approved it last year. No, sorry, 2013, for use in refractory urticaria. So it could be given at a dose of 150 milligrams or 300 milligrams subcutaneously every 4 weeks for 3 doses. I'm not familiar with using cyclosporin, and I hope Dr. Genuino can address this as another option for therapy in refractory cases. So takeaway points: acute urticaria and angioedema usually in these cases have identifiable causes. It's imperative that we make sure that these patients are not presenting with anaphylaxis. And as a precaution, I would prescribe an epinephrine dose for the family until the diagnosis is confirmed. Majority of the cases of chronic urticaria are idiopathic. Therefore, laboratory testing without benefit or clues in the history and physical will be low yield. And so just random or routine laboratory testing is not recommended. The only evidence-based proven treatment for chronic spontaneous urticaria are antihistamines. So the rest of the medications that we've listed here, like dapsone, sulfasalazine, cyclosporin, hydrochloroquine, and colchicine, there's very few evidence that recommends its use, but it's been part of our list of drugs. So these medications should be used judiciously. Thank you for your attention. Go class 90. Bakit ka tumatawa? Hindi si Grace Tamesis.
I-share ko ba? Hello. Okay, thank you very much, Dr. Grace Tamesis. That was a very insightful lecture, and we would also like to thank our sponsors, Menarini and Westmont Pharmaceuticals. Okay, I have a question before I also share my inputs. The treatment guidelines that you shared with us, what year was that in? Is that from an allergy or a dermatology guideline?
It was published by the Journal of Allergy and Clinical Immunology, which was a result of the joint task force for practice parameters by the American College of Allergy, Asthma, and Immunology and the American Academy of Allergy and Immunology. So they formed a joint task force to create the treatment guidelines for urticaria and angioedema and publish this update in 2014.
Okay.
So I can send you a link for...
Yes, if you can share the link, we can send to all our participants. There is a new antihistamine that is here in the market. I don't know if you have it in the US also, the Bilaxten or Bilastine. So it's a new antihistamine also of non-sedating, and it is indicated also for urticaria. Do you have any experience with this?
No. Have you used it?
Yes, I've used it, and it works like any other second-generation antihistamine, and it can be used for urticaria and other allergic conditions too. So I have a comment regarding the need for a stool examination in urticaria. You mentioned history of travel as a caveat for ordering the stool exam, but here in the Philippines, we also noticed that intestinal parasitism is rampant, especially among children, and so sometimes we do a stool exam just to rule out intestinal parasitism in a patient.
Oh, I guess so that would be it's important perspective. So thank you, Dr. Genuino. That's important perspective because in the U.S., there's a very, very low incidence of intestinal parasitism. So typically the history would be the only way to deduce that the patient has traveled to areas that they may be infested.
Another thing is, you mentioned about cyclosporine. Personally, I have not used it for urticaria, and I have used it in T-cell related immune disorders like eczemas, atopic eczema, or other eczemas. But for urticaria, I have not tried it, and I'm usually successful with just using the non-sedating antihistamines together with montelukast. And I've also rarely used oral steroids. As you had mentioned, it's not part of the guidelines. Although in some cases where there's a very acute trigger, like for example, the patient comes to you within 24 hours of ingestion of a certain food and there's an impending risk of angioedema, or the patient already has a history of angioedema, severe or anaphylaxis to that particular food, sometimes do you feel that there is a role for oral steroids in such a case? Like the patient comes to you with a history of ingestion in the past few hours?
That's a good question. I've used oral steroids in cases of anaphylaxis if there is history of asthma, or if the patient is acutely wheezing. So there's a acute respiratory involvement, but not as a part of the treatment for anaphylaxis or the anaphylactic episode. Is that your question?
Yes.
Okay.
So it's not an indication. Another thing you did not elaborate on it, but being a tropical country, solar urticaria could be an issue here. So I have some patients who are foreigners, and when they come to the Philippines and like go to Boracay, they experience solar urticaria, which they did not experience back home. So that's one thing that should be considered in a patient presenting with urticaria in a tropical country like ours. So we are open for questions. Okay, there is a question here by Dr. Santiago. How does the H2 blocker work?
It's just additional.
Because the H1 receptors don't block all of the histamine receptors. I think Allegra only blocks 75%, cetirizine only blocks 50%, Claritin only blocks 72% of the histamine receptors. So addition of another H1 blocker, another H2 blocker can saturate all the empty histamine receptors, and can be an add-on or adjunct to therapy.
Okay, we have a question from Dr. Dualan. Do we have data on the prevalence of chronic urticaria in the Philippines? So I think this data would be available with the Philippine Dermatological Society.
Dr. Dualan, thank you for your question. I actually, in making this talk, I did speak to our colleagues in the Philippine Society of Allergy, Asthma, and Immunology. I met with Dr. Recto and Dr. Casala at the American College of Allergy and Asthma meeting in Antonio. So far, the only prevalent studies that have been published are for allergic rhinitis and asthma. Wala pa pong data on urticaria.
In the Philippine Dermatological Society, we have a health information system, but unfortunately, I do not have the stats. But I can send them to you, to our participants, the prevalence of chronic urticaria. But I would suspect it's also the same as what you mentioned in the U.S. Because it is quite common to see chronic spontaneous urticaria. Even if you do workups, turns out negative. So I think we also have a high incidence of chronic spontaneous urticaria. So any more questions? Just type in if you have any more questions. I think your lecture was was very straightforward and very understandable. I think they understood everything and they have no more questions. So thank you very much, Dr. Tamesis, for that engaging discussion, and we were very enlightened on your lecture. So after this session, an email containing a survey link will be sent to all the participants. Please answer the survey so we can assess our webinar and address more of your preferences and give you materials for this session. After answering the survey, your certificates will be sent to you. Special thanks to our sponsors, Menarini and Westmont Pharmaceuticals. In behalf of the UPCM Class 1990 and the UP Medical Alumni Society, we also thank our collaborator units, the UP Manila Information Management Service, National Telehealth Center, UP College of Medicine Postgraduate Institute of Medicine, Medical Informatics Unit, DOST-ASTI, and Ms. Charisse Orhalo, our host. May we invite everyone to join our next webinar on health informatics, and this would be now the year to be handled by the UPCM Class 1991. So their first speaker will be Dr. Alvin Marcelo on February 3, 12 noon to 1 p.m. So starting February 3, UPCM Class 91, we will be conducting the webinars. And they will be conducting their webinars every last Wednesday of the month from 12 to 1 Manila time. So please take note that there will be 2 webinars in February. The first one will be February 3. That's the first Wednesday, Dr. Alvin Marcelo. And then there will be another webinar on February 24. That's the last Wednesday of February. So subsequently, all webinars for this year will be held every last Wednesday of the month, starting from February 24 onwards. So thank you very much to all our participants, to our speakers, and to our sponsors. Signing off from UP Manila video conferencing room. Goodbye.